All right, welcome everyone. My name is Dr. Daniel Wang. I am a assistant professor in medicine at Baylor St. Luke's Dan L. Duncan Cancer Center, Comprehensive Cancer Center. I'm a medical oncologist focused on mesothelioma and thoracic malignancies. And I'd like to welcome all the attendees and physicians from Latin America, the Middle East, and the United States. As part of our mission to promote medical knowledge through educational programs, the International Center at Baylor St. Luke's in Houston, Texas, in collaboration with Baylor College of Medicine, is honored to host the 15th International Virtual Roundtable to our network of physicians, medical societies, and international medical community. So for today's topic, we're going to be discussing lung-sparing surgery for malignant pleural mesothelioma. Allow me to sort of explain the format for today's program. First, we will have the lecture presentation by our speaker, Dr. Taylor Ripley. And throughout his presentation, please feel free to submit questions via the chat box located in the bottom right of your screen. After the presentation, we will open a virtual roundtable with questions, comments, and observations from our panelists, and we'll address any questions from the audience. Now, before introducing our speakers tonight, I'd like to welcome our Latin American panelists who will join us after the presentation with their opinions. Let's welcome Dr. Enrique Guzman de Alba from Mexico. Dr. Guzman de Alba is a renowned thoracic surgeon in Mexico. He's an expert in minimally invasive thoracic surgery and trained and certified to perform robotic thoracic surgery for the treatment of conditions such as lung and esophagus cancer and mediastinal tumors. He graduated from the University of La Salle with a postgraduate degree in general surgery at the Specialty Hospital Century 21 and a subspecialty in cardiothoracic surgery at the National Institute of Respiratory Diseases. He is the former Deputy Director of Surgery at the National Institute of Respiratory Diseases and a thoracic surgeon at the ABC Medical Center in Mexico City. Welcome, Dr. Guzman de Alba. I'd also like to introduce Dr. Luis Jesus Schwartz Yataco from Peru. Dr. Schwartz is a clinical oncologist and an attending physician at Oncosalud and Clínica Internacional in Lima, Peru, and completed his medical studies at the Universidad Peruana Cayetano Heredia and his oncology residency at the National Institute of Neoplastic Diseases in Lima, Peru. He continued to complete a postdoctoral research fellowship in the laboratory of Dr. Carlos Arteaga at Vanderbilt University in the United States. And Dr. Schwartz has several publications with a vast experience in managing translational oncology projects and clinical trials. Welcome, Dr. Schwartz. And thank you, doctors, for joining us. We will be connecting with you right after Dr. Ripley's lecture to obtain your observations and point of view. Now, it is a privilege of mine to introduce our speaker for tonight, Dr. Taylor Ripley. Dr. Taylor Ripley is the director of the Mesothelioma Treatment Center at Baylor St. Luke's Medical Center. He is a nationally recognized board-certified thoracic surgeon and expert in mesothelioma and thoracic surgical oncology. In addition to mesothelioma, he focuses on chest wall tumors, lung cancer, esophageal cancer, thymomas, and thymic carcinoma. For most tumors, Dr. Ripley specializes in robotic surgery to provide minimally invasive approaches to thoracic diseases. He also practices all facets of general thoracic surgery, including infectious lung disease, benign esophageal diseases, and endoluminal interventions. Prior to joining the faculty at Baylor College of Medicine, Dr. Ripley was an associate professor of surgery at the National Cancer Institute at the NIH. While at the NIH, Dr. Ripley was awarded the NCI Director's Innovation Award for targeting specific P53 mutations for the treatment of esophageal adenocarcinoma. He established the foregut team at the NIH Clinical Center for the management of patients with esophageal cancer. He also started robotic thoracic surgery at the NCI. He established a laboratory in the metabolic reprogramming of thoracic cancer and has continued that work at Baylor College of Medicine. Prior to his faculty appointment at the NCI, Dr. Ripley trained extensively in the care of patients with mesothelioma under world-renowned surgeons during his fellowship at Memorial Sloan Kettering Cancer Center in New York. He also completed a fellowship in surgical oncology at the NCI, and Dr. Ripley did general surgery residence at the University of Colorado and received his medical doctorate from Vanderbilt University. So again, welcome, Dr. Ripley. So again, to remind, the lecture topic today will be lung-sparing surgery for malignant pleural mesothelioma.
Okay, then I'm trying to share my screen. And okay, tell me, do you see the whole screen now? Or is it presentation mode? Looks good. Okay, so thank you guys. I appreciate it. It's a real honor to talk tonight. So I will be brief to make sure we get through this topic well, and happy to talk to the panelists as well as any of the audience about lung-sparing surgery for mesothelioma. Today we're going to talk about the extended pleurectomy and decortication. As many of you know, mesothelioma is a relatively rare tumor. However, its incidence remains a significant disease burden throughout the country. As you see here, the world incidence of mesothelioma is variable throughout the world. However, I would caution that the reported incidences of these can be incorrectly noted secondary to confusion with a diagnosis with lung cancer. Therefore, the incidence is probably higher than it's reflected here. As you can see here, based on the numbers, there's about 30,000 new diagnoses per year in the world, and about 25,000 deaths worldwide. Most of mesothelioma is a result of asbestos, and while asbestos has been banned in about 57 countries now, it still is produced at a high rate in several countries. As you see here, the production has significantly dropped off from 2007 to 2010, but since that time, that has remained relatively stable. Additionally, there's a large amount of asbestos that has been in products, especially in construction and shipbuilding and insulation, that predates bans. And as these buildings are knocked down or they crumble, they continue to provide a risk to patients and families. Asbestos is a term that encompasses 6 different fibers. This term is based on a 1970s definition that is not necessarily mineralogic, but it's a regulatory definition. And as you can see here, these fibers are produced in mines. They're naturally occurring, and they lead to different shapes, which leads to the different aspect ratio as well as the fiber length. And as you see here, this is a frayed electron microscopy view of asbestos fibers. So these are the fibers that likely set up in the pleura that ultimately lead to disease. So unfortunately, malignant mesothelioma is a particularly fatal disease. As you see from this report from 2012, this 5-year overall survival listed here, and even stage 1 disease is as high as 16, whereas the stage 4 survival is reported at 0. So surgery does play a role in mesothelioma. It plays a role in both diagnosis as well as palliative intent and curative intent. In this publication from 2012, it shows that the palliative surgery had a median survival of about 12 months, where curative intent was 18 months. Now note, this is a relatively large group of patients with lack of granularity of the data. Additionally, the patients who underwent palliative surgery were healthy enough for that, And so the difference between unresectable and surgical treatment is greater in different series. So the goals of surgery is a macroscopic complete resection, which would mean removal of all visible and palpable disease while avoiding significant complications. The issue and the reason avoiding significant complications is difficult, as well as this operation is difficult. As you see here, the pleural surface lines the entire chest cavity. So every single organ in the chest or structure, including the nerves, the esophagus, the thoracic duct, the lung itself, the bronchus, are closely associated with the pleura, and therefore the risk of complications exists for every structure in the chest. So extended pleurectomy and decortication is one operation as opposed to the extrapleural pneumonectomy. The extended pleurectomy and decortication has become more popular because while the morbidity is relatively similar at 25%, the mortality is reported at 1 to 5% postoperatively, whereas the mortality is reported at 5 to 15% after an extrapleural pneumonectomy. A more recent meta-analysis reports the mortality of extended pleurectomy and decort at 1.7% and the mortality of EPP at 4.5%. Extended pleurectomy and decort potentially have less frequent complete resections. However, with more experience with this operation, I believe that this operation can achieve this resection just as well. The pulmonary function is preserved, which is relatively obvious given the lung is still present. But hemithoracic radiotherapy can be achieved to the chest without the lung, whereas that risk radiation pneumonitis when the lung is preserved. However, I'll talk about the end of this case is that this is changing with better techniques in IMRT with radiotherapy. So extended pleurectomy and decortication is defined as the parietal and visual pleurectomy to remove all gross tumor. This usually includes resection of the pericardium and diaphragm. However, part or none of those may be resected depending on the amount and the adherence of the disease. The advantages, as we mentioned, is the quality of life is preserved with two lungs. There's a lower postoperative mortality, and there's also other data to suggest that patients who are a little bit older can tolerate it much better. So one of the initial concerns with pleurectomy and decortication was the overall survival would not be as good as EPP. While they have never been compared head to head, this meta-analysis that was published several years ago now looked at all studies looking at the outcome with pleurectomy decortication versus EPP. And what they found was there was no real pattern. There appears to be no overall survival difference of either one of these operations, even though this has never been subjected to randomization. So as you see here, there's an extension of different surgical procedures from the extrapleural pneumonectomy to extended pleurectomy and decort to pleurectomy decort, then partial operations or pleurodesis. And the extrapleural pneumonectomy and extended pleurectomy decort have similar overall survivals that are roughly 15 to 25 months, whereas the other operations such as partial decortications or pleurodesis are much lower. So I'll review one case report of a patient of mine. This gentleman had a left malignant pleural effusion who presented with a large effusion. This was noted when he presented with moderate shortness of breath. And despite the effusions that we see on the left that fills most of his chest, he was performing most of his activities of daily living without limitations, which was primarily working in his yard. His FEV1 was 45%, the LCO was 60%, and he had 13% perfusion on the left. Now, these were taken with this with a effusion in place. So in this CT scan, as you know, there is a large effusion, but as you see here, these lighter areas along the chest and all along are disease. So we performed an extended pleurectomy and decortication, and what you see here in this cartoon, we removed the disease from the chest wall, the diaphragm, and the pericardium, and then we peel the disease off of the lung to preserve the lung. When we do this operation, as you see here, we remove all the pleura in the posterior, anterior, apical, and inferior aspects of the chest to approach the hilum of the lung. You see here, this is the chest wall of endothoracic fascia as the pleura is peeled off. This part of the operation is coming over the aorta, and then you see the segmental vessels deep to the pleura. During the original operation, extrapleural pneumonectomy would then remove the lung to remove the remainder of the disease. However, with a pleurectomy and dechord, at this point in the operation, we incise the tumor, which can be quite extensive until we find the lung, and then we remove this disease. The pleurectomy and decortication can be performed really regardless of the size of the tumor. As you see here, this is a moderate sized tumor of one of our patients, whereas this one is quite thin. Now, this does have disease, but it is almost like peeling normal pleura off the lung at this point. Then, once we remove the visceral pleura, we resect the diaphragm or resect the disease off the diaphragm. The way we determine this is if the disease is not invading the diaphragm, we'll spare what we can. And that is possible usually with a muscular diaphragm. However, the central tendon usually has to be removed, so at least parts of the diaphragm is normally removed. As you see here on the right, the peritoneum or overlying, which was right below this is the stomach and the liver, is easily seen. After this, we remove the pericardium if gross disease is present. As you see here, the edges of the pericardium are here lifted with these sutures, and the heart is overlying it. Once this is done, we remove the disease, and this is the disease from this gentleman, and it can be quite extensive, but despite this amount of disease, we can still spare the lung. After we remove the disease, we reconstruct, as you see here on the left, the diaphragm and the pericardium. In this case, we're reconstructing with Gore-Tex. However, biological material is also a consideration. Typically, those cost a lot more, but they may be associated with a lower rate of IMPI-EMO, although that is debatable. And as you see here, one of the critical aspects of doing this operation is when we remove the diaphragm, we leave a cuff of diaphragm that we're clipping here in this cartoon. This cuff here can be decorticated if there's disease here, but by leaving it intact, this allows sutures to be sewn medially because most of the patients who experience postoperative herniation of abdominal content do along the mediastinum. So this cuff of diaphragm helps prevent that complication. You see that here, and then as that extends anteriorly, the diaphragm is actually sewn to the pericardium and to the pericardial patch, which prevents herniation into the chest of the abdomen. And then this is the same preoperative chest X-ray I showed before. And then postoperatively, as you see here, this gentleman has nearly complete expansion of his lung with removal of both the disease and, of course, the fluid. So looking at our results in our institution, we review the outcome. And as you note here, both EPP and extrapleural pneumonectomy, or when we got a macroscopic complete resection versus exploratory thoracotomy or no surgery, showed a significant survival benefit. These patients' survival benefit was about 23 months with all the patients, regardless of the histology, whereas if we looked at the patients with epithelial alone, the overall survival was just over 26 months. So, are there any trials we're running with surgery? Yes, we have several trials open in our institution right now, but I want to point out one of them was called the IMPRINT study. As you see here from this publication, the IMPRINT study was performed in which patients received neoadjuvant chemotherapy, surgery with a pleurectomy and decortication, and then had IMRT to the chest wall. And what they found in this publication was they had a very reasonable overall survival for this disease at about 26 months, but it was a single-arm study of patients. So currently, this trial is now open here as well as other institutions around the country in which the same trial schema is performed, in which patients have surgery and chemotherapy, and then they're randomized to IMRT the chest wall versus no IMRT to see if there's a benefit. One interesting aspect that came out of that trial from 2016 was the patients received chemotherapy and then surgery, but over 1/3, about 36% of patients who were deemed resectable by imaging had progressive disease after neoadjuvant therapy and were never able to undergo surgery. Therefore, this trial recommends surgery followed by adjuvant chemotherapy for this trial, which is a switch from the original design. However, they still allow patients to enroll who do get neoadjuvant followed by surgery. This is important, but not surprising because the response to chemotherapy is relatively poor. The median survival from cis-PIM, as you know, is 12 months in the original study from Journal of Clinical Oncology in 2003 versus 9 months without the addition of pemetrexed. Recent data suggests that the median survivals with chemotherapy alone are more along the lines of 18 months, which is a median survival of several recent trials. So in summary, extended pleurectomy and decortication can remove large tumors while sparing the lung. The long-term survival with extended pleurectomy and decortication is similar to extrapleural pneumonectomy, and pleurectomy and decortication enables surgery in the older patients with lower lung capacity. The addition of IMRT to the chest wall after surgery is under evaluation with a randomized controlled trial that is currently open. And we have a large treatment team, and Dr. Wang is a critical component and sees many of our patients in medical oncology. But we also have our partners, Dr. Burt, Dr. Groth, and Dr. Cornwell, as well as Dr. Javiri. And then we have a team of pathologists, pulmonologists, physician extenders, as well as a chaplain who help run this program. And I also want to thank our audience, our team, and most importantly, Dr. Sugarbaker, who originally built this program prior to his untimely passing in 2018. So Dan, thank you for the time, and I will turn it back over to you.
Well, thank you, Dr. Ripley, for your presentation. So now we'll connect briefly with you, or back to you, and to kind of discuss further during our roundtable. So next, I'd like to welcome our panelists who will share their observations and their perspectives in regards to today's topic. So I'd first like to introduce Dr. Enrique Guzman from Mexico. So if you'd please like to share your presentation. Thank you.
Sure. Thank you very much, Dan. Let me see. First of all, I'd like to congratulate Dr. Ripley on his presentation. It was very nice presentation, and it's quite a topic in mesothelioma surgery. Here in Mexico, we have a lot of problems with mesothelioma because of lack of a real regulation over the use of asbestos and the way we try to let's say put some regulation on construction and all that. So we have a lot of problems with mesothelioma. But I'd like to share some key points that I think they are important. Surgery should be decided in a multidisciplinary team. I think that one of the most important things is that this disease needs a lot of work of a lot of specialists and a team that is well managed and with a very solid experience with mesothelioma. So it should be a multidisciplinary team who decides whether the patient goes to surgery or not. And I think that it's important to really see that a surgeon should be in the team, and a surgeon that is capable of doing these type of surgeries. Not all chest surgeons, not all thoracic surgeons are comfortable doing surgery for mesothelioma. It's not an easy surgery. It's quite difficult and all that. So it's easy to a surgeon that is not very well trained for this surgeries, or don't do these type of surgeries, to say, hey, just go to chemo and it's okay. There's nothing else to do. Just go to treatment and bye-bye. And I think that's a huge mistake. Now, surgery is an important part of treatment for these patients. And I think that in some years ago, surgery was a little bit in the finger that say, hey, don't operate on them, they're gonna do bad and all that. But I think with sparing the lung and trying to do more conservative surgery, patients with mesothelioma do very well. Surgery provides better survival. That's with the studies that you're already seeing. It has better control of symptoms, pleural fluid, and I think one of the symptoms that is very important to control is pain, chest pain. It's really very dramatic to see the patients of mesothelioma that can't go to surgery. They die with a lot of pain, with a lot of tumor growing on the chest wall, and it's really a very horrible death. So I think that surgery, even though for palliative treatment, it should be come to the table and think of it, and it gives a better quality of life. I think that patients that go to surgery and recuperate well from surgery, they do very well. They get optimistic. They receive the treatment. I think that's important. Here, for example, this is a moderate disease in the left side of the chest. Now, the problem with this patient that he has a mixed histology with a component of sarcomatoid mesothelioma. So one surgeon said, hey, don't get operated on. You're going to die. Go for palliative, and that's it. I think that that's not the better way to go. He went to surgery. That's his post-operative chest X-ray when he went out of the hospital. And here is his chest X-ray about 4 months after surgery. He's on chemotherapy. He's doing well. He's a 75-year-old man. He's doing well. He's optimistic. He's feeling well. He's receiving his treatment. I don't know how long he's going to survive, but I think that getting the disease out and letting him have his chemo without pain, without pleural fluid and all that, that's a better way to do things. This, for example, is another patient. He's another 70-year-old man. He has epithelioid mesothelioma with some parts of cystic mesothelioma. And you can see he has a lot of disease going to the other side of the chest. It seems like the chest wall is invaded. And if you see the mediastinum, you can see and think that maybe these are disease in the nodes, lymph nodes, but it wasn't the case. So he went to surgery. This is his post-op chest X-ray. We were able to get all the disease out, and he went very good. This is a chest X-ray 1 year after chemotherapy, and this is a couple of years after surgery. This is CT scan. You can see there's no disease. He has some fluid, but PET negative, and he did very well. He died about 4 years after surgery with a recurrence on the left side, and he was told we proposed him another surgery and to take it out, and he said, hey, you give me more than I expected. I'm okay. I will keep on chemotherapy. That's fine for me. So, well, he died of his disease 4 years after surgery, but his quality of life was very good. He was a physician. He knew the disease, so he still worked till a couple of months before dying. So I think it's good for the patients. Now, this is important. As Dr. Ripley said, you have to take out all the disease to make sure that you have a very well-controlled disease and you have a very good option to have a very good prognosis, and you have a very thorough with surgery, leaving everything without any pleura, the pericardial patch, also the diaphragm. So I think that is a very good surgery. It's needed, and I think surgeons have to participate more in the treatment of patients for mesothelioma. Thank you for the invitation, and congratulations, Dr. Ripley, on your work and keeping up the work of Dr. Sugar Baker, great surgeon and a great person, and congratulations. Thank you for the invitation.
Thank you, Dr. Guzman. And now, Dr. Schwartz, if you'd please share your opinion and observation from your perspective. Thank you.
Okay. Well, evening. Thanks, Professor Guzman and Dr. Ripley, for the excellent presentations. For my point of view, I'm gonna talk about epidemiology of this disease. What is the reality of mesothelioma in Peru? So this is a slide what we see before. Actually, we see in South America, Peru is like intermediate in incidence in mesothelioma, right? The highest incidence of mesothelioma is from Argentina, and we are similar to Colombia, from Chile, something similar to Mexico. And the highly industrialized countries, we can see, for example, United States and Canada, for example, they had a higher incidence of this disease. As mentioned before, we can say that mesothelioma is most an occupational disease, is highly related with exposure to asbestos. So this is the mortality rate that is very close with the incidence. We see this disease, unfortunately, is with a high mortality rate. The survival in advanced disease is about a year on average. And the curative, even if we offer a curative intent, the 5-year survival is low if we compare with another diseases like breast or colon cancer. So there is a lot of need in new medical treatments or strategy. Even this is a problem that we see more common. It's not in the top of the disease. For example, here in Peru, in first places, we see breast, prostate, lung cancer. And mesothelioma is like 0.29 in the standardized incidence. But in mortality, if you see 0.29, in mortality is 0.24. So what it seems in our reality, we have a lot of patients diagnosed in advanced stage. I will say like maybe 90%, 95% of the cases are like in advanced disease, and only very few are we see like in curative intent. And this is what the limitations in the diagnosis and treatment. Unfortunately, in Peru, we have another diseases, for example, tuberculosis. The patients go to a primary care physician and see a pleural effusion, and the first that comes in mind is this could be an infectious disease. And sometimes this patient can lose very valuable time in the diagnosis. So that's a thing that we face a lot in the National Cancer Institute, patients that have been previously treated with a Crohn's disease, and finally they are a mesothelioma. So again, the predominance is male by far, maybe because again it's related with occupational exposure. Of course, the distribution of the disease is not homogeneous. If we see the areas in red, for example, here is Lima, this is Arequipa, this is cities next to the coast, and these are cities that are related with industry, right? We have industry, mining. Here in the rainforest, they have a lot of exposure because of the mining. So this is the areas that are also in high incidence of mesothelioma. And in here, this is the efforts that we try to make in order to ban the import of asbestos. Here we have a law that was approved in 2004, the prohibition for all type of asbestos, but in that regulation was not include this kind of asbestos. This was trying to introduce later in 2011, but you can see in the previous years, in the 70s, in the late 80s, and in the middle 90s, we import like in high rates of or in short periods of import of asbestos. So unfortunately, the latency period of this kind of disease is long. It's like 20 to 50 years. The consequence is what we are seeing now. So in women, for example, the incidence is quite the same, but in men, in the last decade, we start to see year after year more cases of mesothelioma. Maybe because of the exposure, what we suffer in the 70s, in the 80s, and in the 90s. So I consider this is gonna be a public health problem. We're gonna face more and more of these cases. And as Dr. Guzman and Dr. Ripley said before, we need highly trained surgeons. We need these patients to be managed in an institution that has all the equipments and people with the training to try to face this disease properly. So that's what I want to share. Thanks a lot for your time.
All right, thank you, Dr. Schwartz. I'd like to now move on to our virtual roundtable. And if there are any questions from the audience or observations for our panelists, we can certainly start there. So why don't we start with our panelists? I don't know, Dr. Ripley, if there's any questions that you may want to start off with, or I'm happy to start with some questions myself.
Dr. Guzman, I love that picture. So do you find it challenging to get down in the fissure and take it off the PA when the patients have complete fissures?
Yes, that's why I put that picture, because I think that EPP was a simple surgery compared with pleurectomy, decortication, because you have to take all the disease over the lung, and it's quite a challenge. And you have a lot of you have to have a lot of patience to remove all the disease and go all the way to the fissures and all the way to the pleural, to the PA, and in the hilum too, to remove all the recess of the pleura, so you can take everything out. You have to take all the macroscopic disease out and don't leave anything in the fissure, because I think that that's one of the causes of recurrence, of the early recurrence in patients with pleurectomy decortication. So yes, I think it's very important to go all the way to the PA. And if you have a complete fissure, you have to go in and take it out and try to dissect everything off the PA and all the vessels.
What do you think is so? Do you always reconstruct the pericardium when you take it out?
Not initially. I had some cases that we didn't put any mesh in the pericardium, and I was fine with it. But in one day I had a protrude heart with a cardiac arrest in the time we put the patient on supine position. So we had to turn it back and then put a mesh. And after that, I always put a mesh, even though it's just a piece of mesh that just gets a little bit, because you know, if you have the lung, the theory is that you won't have any problem with a heart, but with after that incident, I decided it's better to put just some patch with Gore-Tex and just sleep well in night. Yes,
I agree with you. We even though in theory the lung should hold it up, we never know how much expansion, especially in the first few days, especially since the disease burden is usually heavier in the lower chest and the lower lobes don't expand necessarily as well as the upper. And I'm always afraid that there is enough space with that lack of expansion that herniation or torsion could really be a problem. So I do reconstruct all these patients.
Yes, I think that's the way to go. And I was very confident. We have a lot of patients with no problems, but we have just one patient, and it unfortunately was in the OR. So when we put it on a supine position, the heart herniated and he had a cardiac arrest. So as soon as we put it back in the lateral position, it restarted without any problems. But I had to reopen the thoracotomy and put the patch in. And after that, I always put a patch. Yes.
Yeah. Dan, any questions, Dr. Schwartz? We could talk about surgery all night long and better not do that.
Go ahead, Dr.
Actually, I have a question. For example, for Dr. Guzman, Dr. Ripley, what is essential in your evaluation? Because as long as I understand my talk with surgeons, the objective of the surgery is to do a total resection of the tumor, right? If I know something is gonna be left, it's preferred just go to systemic. So what is in your workout initially?
Our workup's pretty extensive, and I explain this to patients by breaking it down into two realms. I explain that we're doing a staging workup to see how advanced the disease is, and then we're doing a physiologic workup, and then all the tests fall in those two categories. So with staging, they're non-invasive. The CT scans, PET scans. Occasionally we get MRIs, but frankly, I find those half the time are misleading. And then I do invasive staging. We do diagnostic laparoscopy on all the patients. And we have found that up to 17% have disease in the peritoneum, even with negative PET scans. And I'll also do mediastinoscopy to look at lymph nodes. It's questionable whether or not we should operate on those patients, but knowing that up front helps that assessment. And then the physiologic workup is we get echoes to look at their heart. And although most patients I send to the cardiologist if they have any comorbidities. And then we get pulmonary function tests and VQ tests. Those tests are critical for an EPP. With a PD, they can actually improve. And so even low PFTs are not prohibitive, but I always want to know is if we have to perform an EPP, can the patient tolerate it? So I'll work them up with that in line. The other thing I get are DVTs to the lower extremities because PEs can be a problem. And a lot of these patients with advanced cancer actually have PEs in their deep veins preoperatively. And so it helps us with our anticoagulation strategy to at least know that and manage it. And so I look at all of these things, including their ECOG or performance status, before we make a true decision.
For us, it's more or less the same. We don't do all the patients laparoscopy to see if they have peritoneal disease. Yeah, just if we have the doubt that it might be go through the diaphragm and all that. Everything else is much the same. We always try to have fit patients for an EPP in case we have to do it. But if we are confident that we can make a pleurectomy, decortication, and the patient is limited for the lung function and all that, well, we have to go to surgery with the mindset that you have to do a pleurectomy, decortication, even though it's going to be hard, even though it's going to be tough with the lung and all that. Try to keep up living up the lung. But if the patient is fit for an EPP, well, that's the best way to go because you have all the things you need to know to if you have to do an EPP in the surgery. You don't know that. The other thing that is important, I think, is the right side. One of the I don't know, Dr. Ripley, but one of the places that you have a lot of trouble is the inferior vena cava. normally in the lower chest you have a thicker mesothelioma tumor, and it's easy to have the inferior vena cava very well attached to the tumor, and that's something to think about. But I think that it's better to leave just a little bit of tumor over the inferior vena cava. You can mark it for radiotherapy and take out everything else, because I'm really convinced that quality of life and pain control and all that is better for a patient that you can do surgery and take all the parietal pleura and all the most of the disease out. And if you had to leave something back in the vena cava or something like that, it's better to have radiotherapy in that particular place and the chemotherapy. So most of our patients go into surgery, and I think that we have a high rate of resection completed because of the pre-op workout. Yep.
After your pre-op workup, are there factors that you look at to consider neoadjuvant chemotherapy rather than upfront surgery?
Well, yes. All the patients are discussed in a tumor board in a multidisciplinary team work, and if we think if the patient has a biopsy with an epithelioid tumor, and we think that we have a better chance to resection with pre-op chemo, then we will go with neoadjuvant chemo, and after that surgery. But most of the oncologists in my center, they are, I think that there are more, they have a good surgeons team, so they're very well thinking that, hey, take it out, take everything out, and after that we go to chemo and radio and everything else. So, but sometimes if the patient has a lot of tumor and we think that he has some chance to have a very good response to chemo, or partially good response to chemo, then he will go to chemotherapy before surgery. But that's not the rule. The rule is surgery first, and after that chemotherapy.
When you think about surgery, do you look at the specific type? I know we alluded to the different types of mesothelioma, including epithelioid, biphasic, and sarcomatoid. Could you comment briefly on that?
Yes, obviously we are very concerned about mixed histologies like sarcomatoid, but we think that if the tumor is amenable to surgery and to resection, even though it has some part of sarcomatoid tumor, it would go to surgery. And I think that has given us a good control of tumor and all that. And after that, chemotherapy with a less good survival as epithelioid, but a better survival than no surgery at all.
Yes, in that point, I would like to do a brief commentary, because we have at this point data about mesothelioma that is non-epithelial with immunotherapy. We got this study that is the Checkmate 743, that they perform ipilimumab, nivolumab, and we see that the difference in survival in advanced disease is significantly better in the patients that are non-epithelial, that usually are patients of bad prognosis. If we see the historical series, patients, as we commented before, with advanced disease and only chemo, they survive around 12. In this study, there are 14 months, but the non-epithelial, they live usually 8 months. And with this, with immune therapy, you put at the same level as epithelials. They are around 18 months also. So I think that's an improvement. And maybe a thought is like maybe in the future we're gonna use immunotherapy with curative intent, similar what we do maybe in non-small cell lung cancer with the stage 3, when we combine chemotherapy, immunotherapy, and radiotherapy sequentially or concomitant to in order to improve our outcomes. Maybe it's gonna come in the future.
Yeah, I agree with you on that. I think operating on patients with pure sarcomatoid is very rare, if ever indicated. There are certain patients with maybe stage 1, a very low burden, who are very young and healthy, who we could consider. But overall, I think with the combined immunotherapy, and the data was really strong for sarcomatoid. That's probably the way to go with those patients now. The caveat is the immunotherapy data, as you guys know better than we do, is was equivalent to chemotherapy data with epithelioid. And so now that's fine, but the problem that happens if the patients aren't seen, like Dr. Guzman's talked about, in a multidisciplinary setting, and they get chemotherapy up front, is sometimes that makes them ineligible for clinical trials. So we strongly encourage patients and other physicians to send the patients into our handful of institutions that specialize in this disease, so that decisions on the way they proceed through therapy can be made up front. Because if they receive immunotherapy, it does often tie our hands with subsequent treatments with patients who we know progress so often. We really need a plan A, B, and C, and D. And so it's best, as Dr. Guzman say, have this upfront multidisciplinary talk so that we can really lay out a long-term strategy.
That's an excellent point. And, you know, I think in many of our practices, we're starting to see more integration of immunotherapy as a multimodality tool to sort of improve cure rates and survival. So, you know, I think that's a very nicely laid out point by Dr. Schwartz and Dr. Ripley. Now, do you guys have any other questions in terms of regarding how you guys would recommend community oncologists or community surgeons to reach out to, you know, experts like you guys? It may be different for each country, but just curious to see how that pattern may be, and maybe to our listeners, you know, if they get a patient with mesothelioma, how they should contact someone like you guys.
I can start off with you. What I would recommend is the patients come into a center that specializes in it. That does not mean that they are not under the care of their oncologists or physicians at home. Our country, like many, is very large, and the centers are often hundreds, if not 1,000 miles away from patients. And so I think it's important to come in and see us up front, have a complete evaluation, and then we will work closely with home oncologists, because if the recommendation is to undergo combined immunotherapy or to undergo cisplatin and pemetrexed, we may agree that's the right strategy, but often our home oncologists help administer that, which the patients prefer. It's much less traveling. So what I would recommend is they reach out, talk to us, let's initially evaluate the patients, and then work up a strategy among our team, but also among the local physicians who are critical to these patients' care.
Okay. Yeah. In that point, I was to say I agree. I think what is fundamental, what Dr. Ripley said before, is like when we see a patient, we have to think in the step number 1, 2, 3, the sequence. I think in oncology in general, patients tend to be chronic. We need to discuss these patients in a tumor board because we need to see what is first. First is systemic, first is surgery, and what time is the radiotherapy, what is next to improve, in order to improve the survival. And in these cases, I think these patients need to be managed in the highly specialized centers with the surgeons with proper training, and also the oncologists that know to not only to apply immunotherapy, but to know how to treat the toxicities of an immunotherapy, right? And the specialists around, the pneumologists or the gastroenterologists, because usually with immunotherapy, you can have any kind of toxicity. So I think that's a key point in this.
We have actually seen several toxicity. Dr. Wang and I just managed a patient last week who had autoimmune or immunotherapy-induced hepatitis from one dose or one combined dose of therapy. We've seen a lot of patients with pneumonitis from immunotherapy, and so we send them and work closely with our pulmonologist. And sometimes these complications linger and they're hard to manage and don't necessarily turn around with a short course of steroids. And so it is very important to work closely with our colleagues with these complications as well as the initial treatment decisions.
Definitely, I totally agree. And that patient is doing much better, by the way. So it is a wonder how some steroids can help. But there have been several, very complicated cases that we've seen. So it is nice to have a multidisciplinary approach to all these patients. Are there any other questions for the panelists? Otherwise, I'd like to thank Dr. Ripley, Dr. Guzman, Dr. Schwartz today for their time. And thanks to everybody that have connected today. I'll go around one last time if there's any sort of closing statements. I'll start with Dr. Guzman. If there's anything you'd like to say in closing.
Well, I think that mesothelioma is a very hard tumor to treat, and it always needs to be treated in a multidisciplinary fashion, and always with a team that is expert in this type of tumors. And I think that we're getting closer to have a better survival, better quality of life. Immunotherapy is playing a part on that. So I think it's important for other physicians that don't treat patients with mesothelioma, that think that your patient has some, he can have some treatment. So just refer to a specialist and he will do fine. Yeah. Oh, better.
And then Dr. Schwartz, and I'll wrap up with Dr. Ripley at the end.
Okay. Well, I think the essential is to have this disease in the differential diagnosis at the beginning, because I think it is all diseases that are difficult to treat. For example, sarcomas, mesotheliomas that are non-sensitive to chemo, and you have to do multimodality treatment and combine everything: surgery, radiotherapy. The sequence is essential. So high level of suspicion, if you see a pleural extrusion, think about mesothelioma and refer to a specialized center. I think it's the best we can do as doctors.
I agree with all the points made above, and I would recommend with a high degree of suspicion, when the diagnosis is made or suspected, the evaluation is extensive. I'd recommend seeing a group who can do the evaluation, because all these different components, such as staging, looking at the physiologic assessment of the patients, help define the treatment plan moving forward. And so it's important to actually do the evaluation and take a week or two to get it done before rushing to therapy. And so that would be the main point I would make: is high degree of suspicion, full evaluation, multidisciplinary team, and hopefully we can continue to make an impact on this disease.
All right, and thank you everybody for your time this evening. So before we finish, Baylor St. Luke's would like to recognize and acknowledge the following entities that you see on the screen now. And thanks to each one of them for their support and partnership in today's program.
Thank you, Dan. Nice work. Thank you, Dr. Schwartz and Dr. Guzman.
Yes, thank you guys so much.
Thank you all.
Thanks
Thank
for
you the-
having us.
You too, and have a good night.
All right, thank you. And then
Have a good night.
finally,
Thank you.
one last thing, Baylor St. Luke would also like to invite you to connect to our next International Virtual Roundtable on Thursday, March 25th with Dr. Ganesh Rao. He's the professor and chairman of neurosurgery at Baylor College of Medicine, and he'll give a lecture on contemporary management of brain tumor. All right, everyone, thank you and have a good night.
You too. Good night.
Bye-bye.
Thank you. Good night. Bye-bye.